Hey, hello guys. I just would like to welcome all of you here this evening for our Young Lung Cancer Initiative live webinar with Dr. Laura Petrillo. And she's going to be discussing palliative care this evening with us and how it affects cancer treatment as a whole. I am Leah Phillips. I am one of the co-founders of the Young Lung Cancer Initiative. I was diagnosed with EGFR stage 4 lung cancer in December of 2019. I'm still on my first line of treatment, which is Tagrisso, but I've actually had radiation to my primary tumor in my right lobe. And now just Monday and Wednesday, I have radiation to my spine, L3. I have seen, I'm a huge proponent for palliative care. I have seen a palliative care specialist since 2020 when I was at Vanderbilt. And so this is something that's very important to me. I try to tell everybody this is something you should take advantage of. And I hope tonight we can debunk the myth of palliative care is the same as hospice or end of life. Really, I think palliative care just adds flavor and robustness and kind of rounds out your care team. And many of us are not ever offered palliative care until either they hear it from someone else. I happen to have some family members in the medical field, so I knew to ask for it, but it was never offered. So I think this tonight will be a good discussion. And some people say, well, why palliative care? And a friend of mine said, this was kind of a nice analogy, that, you know, if you're going to need a dress for an event and you go out and buy a dress and then you have to have it altered, that's like oncology with your oncologist. But if you want a custom made dress with a seamstress, you go to palliative care because they customize everything to you as a patient. So without further ado, we would like to thank Dr. Petrillo for donating her time to us tonight. She's a palliative care physician at Mass General Hospital in Boston, Massachusetts. She is the principal investigator of the POISE study, which stands for Patient-Centered Optimal Integration of Survivorship in Palliative Care, for people living with advanced lung cancer receiving targeted therapies. She is also the co-chair of the National Lung Cancer Roundtable Survivorship Task Group with Jill Feldman of EGFR Resistors. So I'll let you take it here.
Great. Well, Leah, thank you so much for having me, Caroline, and the whole group. I'm really thrilled to be here. I've been following from a distance your group on social media platforms, and I'm just really glad that you exist, and just glad to share some time together tonight. So I do have a few slides, but I definitely would love to have this be a conversation, and I'm really happy to talk about whatever is on your mind. But I do think it's great to start with sort of getting on common footing about palliative care and what it is. And I really loved Leah's analogy. That's terrific. And you'll find my presentation's also got a few more analogies, so we'll just keep them coming because I think it's useful. I figured we'd start with our current definition of palliative care. So palliative care is specialized medical care for people living with serious illness, appropriate at any age and any stage of illness, that's focused on providing relief from the symptoms and stress of the illness. And the goal is to improve quality of life for patient and family. I think this is a really important definition. So this was a really kind of market tested definition to make sure that it really resonated with people and captured all the things that we do. The domains of palliative care include symptom management, psychosocial support, wrapping in the cultural and spiritual aspects of care, helping support people during transitions, and helping support illness understanding and decisions. So this is sort of where we are at this moment in time with a palliative care, how we define palliative care. And this is a little vignette about palliative care and how it's helped someone in particular. This is someone named Debbie, who has multiple myeloma, and she shared her story on a blog about how palliative care helped her because she had neuropathy and it was really bothering her hands and feet, and she uses her hands to make money. She's a hairdresser, and she was really isolated, but then with the help of palliative care, they started talking about things like her quality of life and how she's sleeping and her pain, and she got back in control. She says, I'm back in this chair because of the program, and I feel like I'm in the driver's seat. And I think that that is just like such a lovely illustration of what it is to sort of recenter care on these aspects of quality of life. But I do want to acknowledge palliative care did not start out like this. So that is absolutely our current definition. If you are used to VHS tapes, you'll remember rewind. We're just going to rewind in time and take a quick moment to see where all the myths are coming from. Like, what was the history? Why do people talk about palliative care in a certain way? So the very first time people started using the word palliative care was back in the 1940s, 1950s. It sounds like a long time ago. It's really not that long. Like when you think about the history of medicine, as a specialty, we haven't been around that long. But at the very beginning, people in London with cancer would get to the end of their cancer treatment and didn't have medical care that was focused on how to manage their symptoms at the end of life. And so some doctors and nurses opened a hospice called St. Christopher's. It was the very first place that was, named as a hospice. There were certainly instances throughout medicine history of caring for people and their symptoms, but this was a dedicated place. And the doctors and nurses who worked there got to be total experts in managing pain and symptoms and suffering. And they felt they needed a name for the care that they were providing. And they felt that palliate, which is like to cloak, like cloaking symptoms and like wrapping them in a blanket, was suitable to what they were doing. And so that was how that name came about. So palliative care was that specialized care to relieve suffering that was provided. And over time, that palliative care came to the US and to Canada and then spread around the world, that idea of being experts in symptom management. And in the US, it was initially in hospices also and in hospitals, actually. And I would say that this was the idea originally. There was cancer-focused care, and it was like kind of all go for that for a period of time. That was the main focus, and then a switch to this end-of-life focused care, and it was kind of focus on quantity of life and then focus on quality of life. But then we had a really big shift that happened in 2010. There was a study that came out in the New England Journal of Medicine. It was in people with lung cancer, and it was conducted by my research mentor, actually, Jennifer Temmel at Mass General. And what she did was randomize people, like in a drug clinical trial, to either get palliative care from the time of diagnosis versus usual care to see what happened with people's outcomes. So what she was hoping to study was quality of life, just to see, hey, if we start to focus on quality of life and symptoms and how people are feeling, putting them in the driver's seat, if we start all of that from the time of diagnosis, rather than waiting until someone is all done with their cancer with directed treatment and they don't have an option for treatment anymore, what happens? So meeting regularly from the time of diagnosis for people with advanced lung cancer turned out it improved quality of life. It improved patients' and caregivers' mood. There was less depression. There was improved understanding about the goal of therapy. People felt more prepared about and felt in control about what was going to happen and the goal of their treatment. Ultimately, there was less use of what we kind of think of as low value care, which is treatment very close to the end of life that we only sort of know in retrospect is less helpful. And the big kicker in this study was that people who were randomized to palliative care actually lived longer. And so that was why this study was in the New England Journal. That was why it was heard around the world. It launched 1,000 ships because everyone had expected, if you shift from focusing on quantity of life to focusing on quantity and quality, that you might compromise the quantity piece somehow, that they might be convincing people not to receive therapy that would be useful for them, or maybe just that it would distract, but actually it helped. So that was what really kind of got everybody's attention and helped sort of launch palliative care programs. And if you ask Dr. Temmel, she doesn't emphasize that piece because she sort of feels like the value of palliative care in improving quality of life is an end in itself. Like it is the goal, it is a valuable goal, and we don't want to take away from that. And so this was sort of like an aside, and it's been seen in some other studies, hasn't been seen in others, but I think the big point was that it didn't shorten anyone's life for sure, and it helped people just generally feel better. So after that, palliative care started to move upstream. It became the gold standard and guideline recommended. So ASCO guidelines now say, integrate palliative care from the time of diagnosis for all people, not just people with advanced lung cancer, all people with advanced cancer. Now, does that happen? No. But that is the gold standard at this moment as a result of that trial and many others. And so I think of it this way, early palliative care integrated alongside disease modifying care, and with an increasing amount of palliative care as people need it, and kind of like some spikes, maybe somebody has a bad period of pain or a hospitalization and needs more support. Maybe they're having a calmer period and they need less. In this diagram, we have the kind of idea that people are eligible from hospice from the time that they have about a 6-month prognosis, meaning that a doctor could reasonably estimate that somebody may have 6 months or less. And we know in general, people use hospice for a lot shorter amount of time on average in the United States. But the idea is that this is all palliative care. And so when we talk about palliative care, there are some people who will say, no, it's not exactly the same as hospice. And I agree, it's not exactly the same as hospice, but this is my analogy. Palliative care and hospice are like the alphabet and the letter Z. The letter Z is part of the alphabet. It's where we started. It's how we got to be really good at doing symptom management and holistic care. But we also do A through Y. And often when I meet patients, I'll give them that explanation and I'll say, I'm here for A through Y today, and I'll be with you throughout. And if there's a time that we need to talk about transitions, I'll be here for you too. Because I think sometimes people need to have a sense that they can talk with people about that topic too, and wonder what might happen and who will be there for them when it comes to talking about things like that. So I do like to sort of acknowledge that talking about that is part of what we do, to not totally distance, but acknowledge like A through Y. And I think that when it's done right, palliative care can address some of the broken aspects of healthcare. Healthcare is very fragmented now. And there are ways that kind of we lose sight of the whole person. And this is what drew me to palliative care when I was going through my medical training, to be honest. Everything had become so fragmented. We would often, I'd go to my renal rotation and I would be only thinking about kidneys, and then I'd go on my hematology rotation and only be thinking about blood smears. And I think palliative care is just an opportunity to put it all together and really think about the whole person. And I love that about palliative care. But as before, these are the things that we focus on: symptoms, relationships, thinking about relationships with loved ones, regaining a sense of control, thinking about family and caregivers and what their burdens are, and then helping people avoid care that's not helpful or aligned with their goals. This is another analogy. So this is early versus late palliative care, and it's an umbrella analogy. You may have seen this, but the idea is, when you think about palliative care late in the game, and you sort of are, here's a couple, they're talking with the doctor. A few months later, the doctor comes running after them when they're caught in the rain with an umbrella and says, "Here, this will help." And they say, "Thanks, we wish we'd had this earlier." Whereas with early palliative care, you're there with the palliative care team. They hand you the umbrella. You may not need this yet, but just in case. And then when they're caught in the rain, they've got the umbrella to open up. And so glad we had this when we needed it. So that's the idea, is just helping people be prepared. Sometimes talking about things that may be a little bit further down the road, but just to give people what they may need to help them feel as well as they can. Okay, this may be the last analogy, but I can't guarantee it. There's so many analogies here, but this one I can drop in the chat later. It's for the fire department, not the fire. This video is really funny and it's like really nails it. So the idea is, the house is on fire, someone calls the fireman and then they say, "Hey, can you go in there, but just don't talk about the fire." It's like, "But I thought you called me for the fire." It's like, yeah, it's burning in there. They really need you, but don't talk about the fire. And we get this all the time in palliative care. It's like, don't say that you're palliative care because that word is scary. Don't talk about, what might be changing or what we're worried about as a team. Sometimes this happens in the hospital and we follow what the patients need. Absolutely. So if there's a topic that doesn't feel right to talk about, but sometimes there's topics we need to talk about. And sometimes there's just a burning fire, and the people who are in the burning fire often know that the fire is happening. Anyway, just watch the video. I'll put it in there, but we're the fire department, not the fire. So switching gears a little bit, everyone knows we're in a totally new era of cancer treatment. So we previously really had limited number of options for treating cancer: radiation, cytotoxic chemotherapy, and it's only really been within the last few decades that we've had targeted therapy. And as you all know, our targeted therapy options for lung cancer have been exploding in the last 10 years, even in the last 5 years, even in the last year. We just keep getting more and more targeted therapy treatments. Immune checkpoint inhibitors are another totally new kind of therapy. And I even had to modify this slide to add CAR T cell therapy because it wasn't on there when I made this slide, because this slide is from 2018, because it just keeps changing. We're in just such an exciting time with so many new cancer treatment options. And so this isn't just lung cancer, the whole cancer therapy landscape has transformed for lots of different kinds of cancer. And so these types of treatments really help people live longer compared to traditional therapies that we've had before, and it's fantastic. They also do introduce new side effects. In general, when we think about targeted therapy, it's in general better tolerated than chemotherapy, but we'll talk about that piece. But I think one thing that's exciting is that oftentimes when people's cancer is in good control, they can get back to their usual activities. And that really feels different than the way that we would think, or at least, even when I was a resident and would be working with people with cancer, receiving chemotherapy, it would just sort of be like, okay, we're trying to help manage symptoms and manage the side effects of treatment to get to the most tolerable place. But now I can totally see people kind of returning to their lives and, know if a cancer therapy is effective based on, how much they feel like themselves. And that's a really thrilling development of how cancer treatment has changed. But I do want to say, cancer-directed treatment is just one piece of the puzzle. So there's the treatment piece and focusing on the mutations and getting the right treatment, but then there's all these other pieces of the experience of dealing with cancer, symptoms, side effects of treatment, emotions, relationships, how you think about the future. And that's actually my area of research. So I'm really interested in just doing studies to describe the experience of people living with cancer in this new era of therapies, because even the TEML study, which doesn't feel like that long ago, it was in 2010. We had totally different therapies then. It was all cytotoxic therapies. We, had maybe, the first EGFR drugs, but we didn't even know about EGFR. It was just like all just coming online. And so everything has changed. And so there's so much more, some of our foundational research in palliative care about, what palliative care does for quality of life, or what we should be focusing on, what those outcomes are that we try and prevent, like some of the, experiences of intensive treatment at the end of life, or kind of how people understand their illness, all these things, like just what people need, period. It's just different now. And so we're studying that in my research program. This is about immunotherapy, but we'll talk about targeted therapy in a little bit. At least this picture is about immunotherapy. There's new toxicities that come along with new therapies. With immunotherapy, as you may know, it activates the immune system and can attack any system in the body. So there's just all these brand new things. When I first got to Mass General, I joined a research group where people were coming from all different, cardiology, nephrology, hematology, immunology. It was like kind of, I thought, probably like what it was like when HIV was first coming out, because we're learning new things about just medicine, period, based on what these drugs are doing to the immune system, and then kind of revealing, and which is like maybe interesting for scientists, and patients are like, no thanks. I would rather not have this be quite so interesting. But it is just such a wild card, what can happen and affect so many different systems. So it's a whole new ballgame with toxicities. And so that's introduces a lot of uncertainty and a lot for people to deal with. CAR T toxicities is like that on steroids. There's all the new there's immune-related side effects that can be really challenging up front. And the history books are still sort of being written, which is really exciting, but also wild, and can be tough for people and their families to go through. Often, as I mentioned before, some of the targeted therapies and biologic therapies will get a really great reputation because they're better tolerated than chemo. And we don't necessarily say, here's some, drugs to manage nausea. We expect that you're going to be very nauseated. It's, there's a different profile of side effects, but at the same time, we have not done long-term studies on side effects and the cumulative effects of side effects. And there are so many things that are outside of the realm of what drug companies study in the few months that they study these drugs to determine their efficacy. So that is a totally unwritten chapter that we're learning about and that people are living. And I've just picked up on the cumulative toxicity piece too. So you've probably all seen this slide, but in case you haven't, I love it. This is Jill, used with permission. So she points out how, she has animations in the slide when she gives it. And, she's there, you look great when she goes into her oncology office, you look great when she's talking with people who don't know what's happening with her, or maybe they do, and they just are like, wow, you look great. That's in the blue, how care team and people in her life perceive that she feels, but then how she actually feels is in the red. There could be all kinds of things that she's dealing with on any given day and not looking bald or, like she's receiving chemotherapy, might trick you into thinking that there aren't a ton of things that she's dealing with. So I really love kind of how she brings all of this out into the light to say there are a lot of things that are happening. And when we use words like tolerable treatment, we sort of minimize what can be a real impact on quality of life for people. Some other things about the changes that have come about because of targeted therapies and immunotherapies and all of the kind of exciting things that we have now. One of the big focus areas in palliative care is helping support people to have as much information as they want about what to expect. And it's really different with targeted therapies to start to have these conversations with the oncology team and kind of make these plans. And so we did a qualitative study where we talked with people with advanced lung cancer receiving targeted therapies, and we talked with oncologists, and we asked them, how are you having these conversations? And we recorded some of the conversations. We wrote it up. It's in a journal paper that you can read if you're interested. But some of the patients told us, what they were learning is, this is not a death sentence. It's a long-term managed disease. There's medications and treatments. They described how getting the diagnosis of lung cancer was terrifying, but then learning about a targetable mutation really changed how they thought about the diagnosis and gave a lot of hope appropriately. It did mean, though, that some of the questions that people might have about what to expect from their cancer not only can't be answered, I mean, that's kind of a given. There's no way to give a direct answer, but also it just made it less likely to be discussed, even if somebody was very curious and wanted general estimates. And the oncologist sort of gave us a clue about why. They're dealing with uncertainty too. They said, one oncologist said the landscape is changing and shifting so quickly. A conversation you had 3 months ago could be completely different because there's a new approved therapy or there's something in trials. But we did learn that some people were really curious still about how long do I have and wanted to know, and sometimes would go on forums and kind of talk to people to try and get a sense about that so that they could have some ideas in their own lives. And another patient said, there are some patients that have been on this targeted therapy for 10 years, is what they learned from their oncologist, and are still doing well, and it's not a cure. At some point it'll stop working, but she didn't say the average. This patient emphasized how her oncologist said, she really just talked about the person that was on it for 10 years. And they wanted some more detail than that. They wanted to know, what's the best case, worst case, most likely, what's the average, like, what can I expect? And it's really understandable that oncologists are very excited about the most optimistic outcome and want to instill that hope. But sometimes people are curious and can have a hard time getting that information if they want it. I thought this captured it so beautifully, kind of the two sides of the coin of uncertainty, that where there's uncertainty, there's hope, because we don't know how long it's going to last, but because we don't know how long, there's hope it's going to last a long time, but there's also fear it won't last long at all or even work at all, but there's still hope. You can see just this vacillation back and forth between the hope and the worry. And then uncertainty just came through as such a huge issue for the people that we talked to. Some patients said things like, I haven't found an answer about how not to think about living and dying every day. It's enjoying every moment, but in the back of your head, planning not to be there the next time this moment happens. People struggled with decisions about retirement and other big decisions, investments, saving their money, going on vacation. And caregivers talked about that too. One caregiver said, life isn't the same, even though she's the one dealing with it. It's part of me that I feel has been lost, just because they couldn't look as far into the future as they used to be able to. When we talked with people and we were trying to do this study about communication, we also just were like, what do you need? We tried to just learn in an open-ended way what people's needs were. And we got a really clear quote from one patient about wanting just a very integrated support system, which sounds a lot to me like palliative care, but just to say, we view having a therapist or social worker, having a team of people who are specialized in this duality of kind of living as well as possible, but also wondering and feeling uncertain about the future and how hard it is because people are hurting. And even if they're doing fine medically and their scans look good, the doctors aren't necessarily addressing it when they go in for their visits. So we heard very clearly that there was a need or a desire among some patients for support for coping with uncertainty. But we also learned that people wanted connection to their peers, which I would have to say, Young Lung Cancer Initiative, all of the targeted therapy groups, longevity, like the patients have really led with their feet in this and self-organized in a way that is just blows me away. So I think this part is met for so many people as a function of the incredible work that you do. But it is something that people craved. We collected these data, you know, maybe 6 years ago, 5 or 6 years ago. So I would say that this has even grown exponentially since we first started talking with people, but still this was a need. And then people actually wanted more kind of help with things like nutrition and exercise counseling, because they were like, I need to settle in and figure out how to live as best I can. Like I need to figure out how to do the things that I can control. And I'm not getting that information from my medical team about what I need to be doing. And they wanted educational resources of places to go and look. To me, a lot of this started to sound like survivorship. Now I'll say, we used to think of the term cancer survivorship as being the idea of someone who's gone through cancer treatment, like say for early stage breast cancer, has finished their treatment, and then they're after this whole idea of kind of like acute survivorship and then extended survivorship and permanent survivorship. I don't know who ever put permanent survivorship on a slide, because they just, the reality is like people are always there's always sort of an idea that you're in monitoring and surveillance, and how I think people wish they could totally close the chapter on it, but it totally misses an important piece of survivorship, which is that all of these concepts that have arisen in the idea of survivorship are applicable to people dealing with cancer all along the spectrum of dealing with cancer. And people with early stage cancer need support for survivorship. People who are diagnosed with advanced cancer or who progress to advanced cancer need survivorship. And people who have end stage cancer need support. And so the NCCN definition of survivorship and NCI is that an individual is considered a cancer survivor from the time of diagnosis through the balance of life. But then survivorship care, like I said, traditionally, if you go anywhere and look for survivorship care, it's often this idea of surveillance for cancer recurrence, psychosocial support, management of long-term or treatment side effects, care coordination, and then health promotion through behavioral change. And we were like, is there somewhere in the middle where we can sort of have some of these aspects of palliative care that are really relevant for people with advanced cancer, but also start to think, what do people need in this survivorship space? What are the health promotion through behavior change pieces that we could integrate? What are the elements of kind of psychosocial support related to dealing with uncertainty? What are the care coordination pieces, or thinking about the long-term side effect pieces that we could integrate with what we know works from palliative care? And really, the way that we thought about this is just, it's good patient-centered care. So this is the model that we're thinking about more now, in terms of blending survivorship care and palliative care, to sort of not say that survivorship care is only for people who've completed definitive therapy, because if we're going to think about everybody as a survivor from the time of diagnosis throughout, how does that survivorship care look? And also we acknowledge that people aren't thinking of palliative care upfront for people who have really promising options for cancer treatment, even if it has been demonstrated to be useful, in part because of this incredible optimism people have that I was showing you. You know, they have a diagnosis, but then they have a really good option to offer. And so they're not necessarily thinking from the get-go about palliative care as they were for a short period of time when those first studies were coming out. So we've been trying to advance this idea of advanced cancer survivorship and kind of blending survivorship care and palliative care. But I will say this is like far from mainstream at the moment. I think people can kind of try and get into some survivorship programs. There are some survivorship programs around the US who will accept kind of like who will see patients with advanced cancer and sort of start to tailor things to them like one-off. And there are some palliative care programs that, because they're used to seeing patients from the time of diagnosis, will think about ways to sort of tailor, but this isn't at all standard. So I'll just say this is like a vision for the future of blending these two ideas. And I think that's all I have. I'm happy to take questions. And I also, let me just stop share. I want to say too, I'll drop a few things into the chat about links. So I know that one of the big questions was how to access palliative care. And there's actually a website called getpalliativecare.org, which is where people can find palliative care clinicians around the US. And I'll also drop in that fire department, not the fire.
Well, I really found everything you had to say very informative and really just, I don't know, eye-opening, because so many people don't know what palliative care is. I do have the questions that were kind of asked in the group, some of them that you didn't hit. So I thought maybe we'd start there, and then we'll make sure that we have some time for people in the audience just to ask questions. So one question is, why do you think that people aren't automatically referred to palliative care doctors or nurses from the get-go?
So there's a handful of reasons. I think one of the reasons is because at the moment, most places, I'd say the vast majority of places, rely on the oncology team to place a referral to palliative care. And so they have to think of it. And there are some oncologists who diagnose someone with advanced stage cancer and place the referral automatically. I have a few colleagues who are like that, and I'm always happy to see their patients. And kind of, even if they don't have a ton of needs at the moment, we check in, we get to know each other. You know, we develop a relationship so that I can be there for them when they need me. But they're the exception rather than the rule. I think the part of the reason it doesn't happen automatically is in part because some oncologists still have an outdated concept of palliative care. They may not have totally, known about the revolution that happened in 2010. Even with the ASCO guideline, they may have uncertainty about what palliative care can provide for their patients. They may have a perception that it's only necessary late in the stage of someone's experience with cancer. And so that may be part of the hesitation. And then there's a real issue with a limitation of palliative care resources. So often, the idea of early integrated palliative care is palliative care provided in the clinic. And the vast majority of palliative care clinicians in the United States practice in the hospital, and also our consultants who are there to manage acute pain during hospitalizations and help with kind of goals of care conversations. And there are just a lot fewer of us who do outpatient palliative care in the clinic. So I would say most NCI cancer centers have a palliative care clinic, but they usually don't have nearly the capacity to serve all of the people in the clinics, in the cancer centers where they are with advanced cancer. So they'll often sort of triage, and it becomes kind of this informal thing where the oncologist will sort of know the resources in the institution and sort of hold on and refer people when they have a high burden of pain, or like another symptom need that's hard to control, or another issue like they need psychosocial support that's specific to what we do, or support with decision-making and goals of care. Like I would say sometimes there's, an older adult who might be from the get-go not certain about the benefit of like the risk-benefit balance and want to talk it through with someone, or just, situations like that. So people will sort of triage themselves, rightly or wrongly. But I will say that if a patient comes in and says, I've heard about palliative care, is it right for me? We are so happy to take that referral, and we try and ask our oncology colleagues to always pass it along to us, because we think everybody deserves to have that opportunity to meet palliative care and learn about things that may be helpful for them, that they may not have had the opportunity to talk about yet, and at least establish that relationship so they know who to call and can have a familiar face and someone that they've established with if they need them later.
Perfect. Another question was, what are some examples of things palliative care teams can do for people who are on the TKIs that are at stage in their journey, I'll say, that they're having very minimal side effects, they're not on chemotherapy and they're not really experiencing pain? Are there other things they can do that palliative care can offer these patients?
So we When I meet somebody for the first time, I take a really pretty big inventory just to be like, how's everything going? We'll talk about physical symptoms. We'll talk about psychological symptoms. Now, I'm not a psychologist or social worker. Sometimes I wish I had enough time to go and train in like all these different disciplines because we touch on so many different things and intersect with so many different things. But I will do a psychosocial assessment and some psychosocial care as well. I think one of the big things that we've seen in palliative care that actually is responsible for some of the benefit is that we help people with coping. So kind of helping people think through ways that they can respond to challenging situations that actually can be really worthwhile to focus on when things are going well. So sometimes we'll do coping support, just building those muscles together. And then sometimes we'll also talk about kind of the future and kind of what to expect and make sure that people have all the information that they want. And if there's like information that they're curious about that they haven't had the opportunity to get, we'll do joint visits, we'll pass, along to the oncology team. I'm often kind of trying to support and amplify the voice of both the patient and the oncologist to sort of like work in harmony with everybody. Not usually kind of going rogue and sharing my own impression about prognosis, but I do try and make sure that I understand, someone's information preferences, what they want to know about, if there's somebody who's important to be there with them when they're getting information. Like I try and get all of that information in place so that it's there for the next person too, if it's not me who intersects with them again later. But so there's a number of things we can do. I mean, I think to me, the most important thing is building a rapport so that somebody knows me and trusts me so that if they need me later, that I can be there for them. So sometimes we'll sort of check in and then we'll be like, you know what, we'll check back in a couple months, or like, we'll just periodically check in a few times a year just to make sure everything's still going okay. And so that they just know that I'm here for them.
Perfect. A hot topic amongst the young lung patient group, one of them that I can think of is diet plans. You hear don't eat sugar, don't do this. People want to tell you you can cure yourself by eating mushrooms or whatever it is. Would you say is a general kind of rule of thumb for lung cancer patients in general in terms of diet?
Yeah. So I generally shy away from extremes. So I definitely think anything that's like cut out all sugar. If we had that information, we wouldn't need the drugs that we have. We would just be like, cut out sugar and you're good. Like, I think that there is something to, I don't discount that there is something to the power of food and its intersection with health. I don't discount that, but I do think someone kind of drastically cutting all sugar out of their lives could really not be consistent with having a sustainable approach to eating that then, allows them to, be present in their relationships in the way they want to be, getting enough nutrition and kind of calories. So I definitely try and think about moderation. I do think it is relevant though to think about healthy eating patterns in general, because so often, again, just rewinding a little bit, when we would meet somebody with advanced cancer, we'd be like, eat ice cream for every meal. Cause we don't know, somebody's going to could lose a lot of weight tomorrow, and people would be dealing with chemotherapy side effects and be really nauseated. So when they had an appetite, we'd be psyched, just like, sky's the limit, eat whatever you want. And I don't think that that's the message that fits with where people are right now, dealing with cancer with any kind of era of these effective therapies. So I do think it's worthwhile to talk through, if somebody didn't have kind of coming into everything a healthy eating pattern, to have the opportunity to talk with a nutritionist and kind of go through a day. I think it is really worthwhile to kind of think about making sure that people are getting the right amount of each of the macronutrients, the right amount of protein in their day, enough carbohydrates, enough healthy fats, and just think about eating, I think there's a lot of evidence for a plant-based diet and kind of incorporating as much fruits and vegetables as possible. So I would say that's sort of where the pendulum is swinging back to a little bit, from being like, just eat ice cream all the time, or like have whatever you want to eat. And like, we're not going to go there because we don't know, we don't want to restrict anybody in any way, to sort of being like, we fully support people in thinking carefully about their food choices. I mean, like I said, I avoid extremes, but there are dietary recommendations that I'll share. I can have them right at my fingertips, but I could maybe email them. Like we tend to refer to kind of like guideline things that are along the same lines as the like what's recommended for healthy Americans.
Okay, that's perfect, thank you. What are some recent findings on holistic treatments in relation to helping with sleep? A lot of us I know deal with the insomnia. Sometimes it's because our brain is turned on and we can't shut it off. Sometimes it's due to medications or how you're feeling. And also the musculoskeletal pain without impacting like, other organs like liver or kidneys that are gonna put us at risk for, more problems down the road.
Yeah. So in terms of sleep, I actually think the most valuable thing for sleep is CBTI, cognitive behavioral therapy for insomnia. In many studies, it's proven to be really effective. And it's a really intense program. I think anybody who thinks it's like therapy, like going to lie on a couch and talk about your mother, it's not like that. It's like a rigorous idea of keeping a notebook about your sleeping patterns. Sometimes it involves some sleep restriction to try and make sure that somebody's like really tired when they're going to sleep, trying to do all of the things about sleep hygiene. But it's a standardized kind of course of therapy that has been demonstrated to be very effective. So I would say, and then of course it's the piece is also about like dealing with the thoughts that come up and like, using relaxation and all those things. So if someone has the time to engage in that type of therapy, I think it's really worthwhile. I do think it's also very relevant to take a really exhaustive history and like look at drugs that somebody is taking, make sure there aren't side effects that we're missing or not thinking about, make sure that there aren't undiagnosed conditions like sleep apnea that could be affecting somebody's sleep pattern. So just really being thoughtful about all the things that could be happening that are affecting sleep. And then, sometimes we'll prescribe sleep aids. I think it's always worthwhile to try melatonin over the counter first. But I like to think first about why isn't somebody sleeping? Like, are there like simple things that we could do? Are there things that are more kind of intense but non-pharmacologic, like CBTI? There's some apps on people's that you can get on your phone that do CBTI, and like all of the mindfulness apps have sleep options like Calm and everything. And I think that those can be really powerful. But then we also have pharmacologic options to help. And then in terms of pain, again, I think we try and have sort of a stepwise approach to how we manage pain. Often when I'm thinking about pain, I'm like first trying to understand what's happening with the cancer, like what's going on with this pain, where is it coming from? Is it a side effect of treatment or is it something related to cancer? And if it's related to cancer, is it a signal that the therapy that somebody's on isn't working and we need to have a conversation or do some imaging? Is there something like radiation that's necessary? Like I'm always sort of thinking along those lines. So I'm not just treating and masking a pain that could be a signal that we need to know about and act upon. But then for chronic pain, we'll often start with things like, heat, ice, activity modification, simple over-the-counter treatments to see if it can be helpful. And then, progressing on to kind of for moderate to severe pain, opioids still remain kind of our gold standard for cancer pain, but we always kind of use the least amount possible for the shortest duration possible. And I'm starting to incorporate buprenorphine a lot more into my treatment, which is, I think, a good primary analgesic and helps us avoid some of the opioid challenges that people face.
Awesome. I know that fatigue is kind of like one of the biggest side effects of either whether you have active cancer in your body or if you're on cancer treatment. It's very common, and I think puts the younger demographic in a sticky spot because we're, a lot of us have young children or we're trying to work or we're, still going to school. And, what can be done, or are there any lessons from that long haul COVID that we hear about with treating chronic fatigue in cancer patients?
Yeah, fatigue is one of the trickiest ones for sure. We definitely always start with, again, just an inventory. How are you sleeping at night? How's your nutrition? How's your mood? Because sometimes like depression can masquerade as fatigue. There's just so many things that are worth kind of exploring to make sure that we're thinking about exhaustively. Then we also think about, if somebody on immunotherapy, do we need to think about the adrenal glands? Like what's happening that could be driving this, that could be addressed in terms of an underlying cause. And then the things that I think about are trying to understand somebody's activities throughout the day and making sure that they're pacing themselves, they're using their good energy, like on their good time of day for the things that are really valuable for them, and then kind of conserving at other times, making sure that they're incorporating rest when they need to. And and just some of those kind of behavioral tricks for energy conservation. We do know that getting increased physical activity can be helpful for fatigue. And I think it's a hard thing to hear when people are fatigued. It's like, please don't just tell me to exercise. And so I try and see ways that people can start small, start manageable, just build in activity so that they can see how it works for them. But there are good data about physical activity helping with fatigue. And so in whatever way makes sense, the activity we're sort of lacking there, seeing how we're sort of lacking in cancer specific nutrition guidelines. We're also sort of lacking in cancer specific physical activity guidelines for people with advanced cancer, because, it'll be like, the regular US standards of like 150 minutes of moderate to intense exercise a week. And it's just, that's wild. I think people don't necessarily may feel put off by something that's so extreme. So I do kind of say start manageable, with incorporating walks, incorporating, some light weights. I think strength training is really underemphasized and is really valuable, and can help with energy levels too. And I always say it's counterintuitive. People think I'm fatigued, I don't want to go exercise, or I can't go exercise. Not that I don't want to, but I can't. But starting to incorporate that in just a modest way can actually help people have more energy.
Great. I think there's two big questions that I think people will be excited or tuned into specifically. And I'll ask the next one in a minute more about kind of some tips that you have for some side effects. But a hot topic right now is this kind of integrative oncology kind of treatment. And do you feel that there's any evidence or things like Reiki and acupuncture, massage, meditation, THC that really do work alongside the more traditional chemotherapies or TKIs to let patients live like healthier and longer lives?
So I think there are very many valuable things within integrative oncology. I think with all of these things like integrative oncology, palliative care, survivorship care, I think people often will think about them as like this whole package, and each of the pieces within them have value and have evidence behind them or not, or anecdotal evidence. But within integrative oncology, like among the things that you've mentioned, certainly acupuncture can be very useful for pain, for nausea, for a number of symptoms and side effects. And so I do think that there's absolutely value in adding that. Often we'll have the acupuncture team come during infusions and the infusion center in our cancer center. And I always encourage people to pursue that. Marijuana, similarly, the data are complicated with marijuana, but in general, I do think that there are benefits for pain, for appetite, for sleep, for nausea. Like there are a number of ways that marijuana can be helpful. I used to practice in California and would write cards and give people prescriptions, but now I'm in Massachusetts, so I refer to somebody else who does that because it's not within my health system. It's not a thing that we can do, but I do always talk with people about it because I think, particularly for those ones that I mentioned, like, appetite, if somebody's having difficulty with that, it can be really helpful. So I don't discount it at all. And then meditation, I think it's huge. I think it's huge. Like, I think management of stress through meditation can be enormously valuable for a quality of life. It can be helpful for sleep. It can be helpful for regulating mood and dealing with and just coping in general. So I'm a huge proponent.
Great. Okay, so now we're going to pick your brain. So we would like to know some of your favorite go-tos for the common side effects of TKIs. For instance, like skin and nail issues, or the cramps that, I get really bad cramps in my feet and in my toes, and my fingers, legs, especially when I'm sleeping. I know a lot of patients that deal with neuropathy, and then of course, like the diarrhea and the nausea. So I don't know if you have any go-tos that you would suggest to people, because that's always what we see posted in the patient group. Oh my gosh, my diarrhea is so horrible. Does anybody have any suggestions about what I could do?
Yeah. Thank you for asking. I think I'm going to see if I can pull up something. So I actually have a table with TKI side effects and suggestions. Now, I will say the data are lacking. So oftentimes I do feel like people will get specific recommendations either from the oncology team, and sometimes you all get it from each other in a way that can be really extraordinary, particularly with skin. Like I feel like in our qualitative studies, we would hear like people being like, oh, I learned about a certain type of like silk pajama to put on after I put on my lotion. And it was like from the patient forum group. And you would never get that from your oncologist. But I really appreciate that. But just give me a moment, and I'm going to pull up this table. There was a moment in time where I put everything I could find that was evidence-based and then added like anecdotal stuff too. But unfortunately, our data about this is limited. So initially with the TKIs, the European Supportive Care Society put out skin toxicity guidelines, but they were for earlier generation TKIs that were more, that had worse skin toxicities than some of the current generation, although that was before amivantamab. So I will say that that maybe is going to get walked back a little bit. Sorry, it's just still loading this manual. I'm just trying to talk while I get there. But yeah, often like this is a place where I would say for symptom and side effect management, we're partnering more closely and sometimes even deferring a little bit more to the oncology team to kind of for the ownership of the TKI side effects. But I did pick all of my oncology colleagues' brains, which are in this table. So let's see. Let me see if there's anything of value to add to what you all already know, because I'm sure that you're all experts. Okay. Okay. These were, okay, just listings of all the side effects to start. And then, so I mean, I don't have like specific go-tos, but like I'm thinking about topical treatments, obviously. And again, this is usually stuff that's prescribed by the oncology team rather than by me. But things, you know, there's some of this does come from that supportive care one from the European group, but things like, you know, the antibiotic creams, topical steroids, oatmeal baths, and then sometimes with obviously with dry skin, avoiding excess bathing, but then putting emollient creams on right away after you bathe. So I kind of try and tailor, honestly, like there are so many different TKIs that have sort of different side effects. And so I try and think about what is the most common side effect and then what is my patient dealing with? Is it fissures? Is it rash? And then provide some of these things. But it's just to say like a lot of different stuff. A lot of different stuff.
That was a
And
good question.
some of this is like behavioral, some of it is drugs that we use. And then, yeah, I do find that with diarrhea, so many of my patients can actually get to a good place just by diet alone, just by modifying what they eat. And then I have patients who absolutely, you know, need to make sure that they keep up with their Imodium or like, you know, have it on hand or have days when they take it prophylactically. Thankfully, you know, I think most people, especially with the later generation drugs, are in an okay place with it, but kind of get to know their bodies and like know what they can eat and what they can't eat and when they may need to be reaching it for more often. You know, sometimes for cramps, you know, we definitely think about vitamins and making sure people's, you know, iron is replete and thinking about these vitamins for supplements. Some people do recommend tonic water. I think stretching is valuable. And sometimes, you know, if somebody has Ativan already for like a scan and they're having a really bad cramp, I think it's not the worst thing to try it to see if it's helpful, since we use benzodiazepines as muscle relaxants, but it's not something I would say to do every day. Unfortunately, I know there was a question about edema. The edema that's associated with tyrosine kinase inhibitors usually, unfortunately, isn't responsive to diuretics like Lasix. And so even though we use them, we still do kind of say elevation, compression, all of these things for the management of edema, just because we acknowledge that it is less likely to be useful. And then, yeah, sometimes like the answer to a really kind of quality of life limiting side effect is a dose modification. And that's something we sometimes will be having a conversation about. And I know it's hard to think about that possibility because people want to have the option of the drug doing the best that it can, but I hope that shows you like there's complexity, there's like a lot of different things that you can recommend, and we try and tailor it to what somebody is specifically dealing with. So I wish I had something sexier to share with you about. Like,
That's great. I think you did a good job. That was big. That was a big question. It is almost 8 o'clock. We have about 2 minutes left. Time flies. And I just, if you have like 2 minutes, if you would mind if people on that are actually tuning in, if they have like we take maybe one more question, if anyone wants to raise their hand to ask that question. If the audience doesn't have any questions, then doesn't look like anybody's raising their hand. Okay, well, hopefully that means you answered all the questions and I asked the right questions. So I just really want to take a minute to thank you again for joining us tonight. I know in our busy lives, it's hard for people to tune in right now, especially around dinner time, different places, but I know this will be shared on our website as well in our patient groups. So I know a lot of people will take advantage of listening into what you had to say tonight and what you had to offer. And hopefully we debunked the myth of palliative care means end of life, and it really doesn't, that we can all benefit from palliative care.
yeah, absolutely. You can share my analogy of if palliative care is the alphabet and hospice is the letter Z, and we often are thinking about A through Y. So
I like that.
yeah, great.
Well,
But I
thank
also
you
love
very,
your
very much.
Yeah, of course. It's such a pleasure to be here. I really appreciate everything that you do for the lung cancer community, and it's lovely to meet you all.
Thank you. You have a good night.
You too. Take care.
Bye-bye.